Dr. Binmoller is the Director of Interventional Endoscopy at California Pacific Medical Center in San Francisco, California. So, tell us about the technique of underwater en-bloc resection.
Well, let me first tell you a little bit about the underwater resection technique. When using water instead of air, we are able to eliminate the need for submucosal injection. And the reason for this is that the muscularis propria on the outside, it stays round and it does not follow the involutions of the mucosa and the submucosa when the lumen contracts. So even though we see folds in the lumen, the muscle layer on the outside stays round. And it stays round even when there is vigorous peristalsis. And we know that from endoscopic ultrasound studies. In 2012, we published our paper using this underwater technique to resect large sessile colorectal adenomas. And we were using a piecemeal technique at the time, so the conventional EMR technique. But over time, over our developmental work, we observed that we were able to resect very large areas that far exceeded the size of our snare. And the reason for that is that when the superficial layers, the mucosa, submucosa, are contracted, we can capture a larger surface area. So we started to attempt en-bloc resection because obviously it would be preferable to get an en-bloc specimen. So we have modified our technique from a piecemeal resection to an attempted en-bloc resection, and that's what we're reporting in the paper.
So can you explain a little bit more about how water eliminates the need for submucosal injection?
Air distends the colon, and water does not. It's actually that simple. So, as endoscopists, right, we work inside the colon lumen, and we insufflate air to visualize the surface of the mucosa. What we don't really appreciate is how much we distend the lumen of the colon. If you observe a gas-distended colon from the outside, as a surgeon might, and you transilluminate, that's when you become aware of just how thin, I mean literally rice paper thin, the colon wall becomes. You can see all of the vessels on transillumination, the vessels in the submucosa. The need for submucosal injection actually derives from our desire to increase the thickness of the colon wall, to actually create a thickness that's more like the native thickness. So it's to counter the effect of this wall thinning from air insufflation.
So can you tell us a little bit about the results of the paper?
This was a prospective trial, and 50 patients met the inclusion and exclusion criteria, total of 53 lesions. All of these were 2 to 4 centimeters in size, all laterally spreading tumors, so they all had a Paris 2A component to them. And we were able to achieve endoscopic en-bloc resection in 55% of the patients, so that was 29 patients. And of these en-bloc resected specimens, surgical pathology showed an R0 resection in 79%. So the vast majority. In some of the patients, there was cautery artifact, and the pathologist could not verify that the margins were indeed clean. We had follow-up in 40 of the 50 patients. And of those patients, we found residual adenoma in 2 patients. So that was a 4% residual adenoma detection rate on follow-up. And of note, we did get at least 6 biopsies from the scar site, the post-resection site, on follow-up.
55% success means 45% of the patients failed en-bloc and required piecemeal resection. Is this a glass half full or glass half empty situation?
Glass half full. Remember, the conventional approach to resection of large lesions has been to limit this using a snare to lesions less than 2 centimeters in size. And so we are really extending this boundary now to lesions greater than 2 centimeters, and we're able to achieve en-bloc resection using a snare in lesions greater than 2 centimeters in over 50% of the patients. But I also want to, so I'd say these results are definitely, if anything, encouraging, and I do think they can be improved. for example, with better snare designs. But the other point I want to emphasize is that even though we call this piecemeal, all right, so technically if you require a second ensnarement, this is piecemeal. But we're attempting to remove the entire lesion en bloc. So we're getting the majority of the lesion the first time around. The residual tissue, if any, is going to be at the very margin, and it's going to be just a very small amount. So we're sort of trimming the margin when necessary. And sometimes this is tissue, some residual that you only see with high definition and with MBI, interrogation of the margins. So we always use a small snare to resect this residual. In a way, rather than piecemeal, I'd rather call this attempted en bloc resection with margin trimming if needed. So it's really a different approach from piecemeal.
Were there any adverse events?
No perforation, so that's good. Yes, we did have one patient who had a delayed bleed, and we had one patient who had abdominal pain after the procedure. Nothing serious, so these were not serious. So that is a complication rate or adverse event rate of 4%.
Is there any limitation or drawback to this technique?
Well, really, the drawback relates to the underwater technique. So obviously, in a poorly prepped colon, you're going to have difficulty with visualization. So you're going to need to do what's called the water exchange, where you're exchanging the contaminated water with clear water. And that's part of the method. And I do all my colonoscopies starting, I switch off the gas, and I do my colonoscopies from begin to end using water. And so by the time I visualize the lesion, I really have a very clear view. I'd say that's really the only drawback of this technique. It's the issues with visualization with a poor prep.
Thank you, Dr. Ben Muller. This concludes our interview.